Hello everybody, this is Dr. Pat Sulia again with the next installment of my educational videos. We're going to talk about the DOT physical in a different way. 2 years ago I did a video showing how I do a physical, DOT physical here in my office. Today you can consider this to be part 2. I'm going to talk a little bit more about the history taking part of it, some of the myths and facts about what you need for a physical, which has to tie directly into the history part of it. And then with my lovely assistant here, my mock patient Amanda, we're going to demonstrate for you some of the abnormal stuff I may be looking for. So a lot of you who've been to me, you see me checking things, and then I'll say, okay, this is okay, you're good, or whatever, but nobody really knows what it is I'm looking for. So we're actually going to show you that today, what some of the abnormal things that indicate that there are further problems, things that need further investigation by your family doctor or specialist. So just to get right into it, I'm going to show you the history part. So I took some actual old patient files. Obviously the pertinent information is blacked out. So this is what the history taking form looks like. And the reason why I picked these patients is because they did it right. So how they indicate everything on the form, minus the handwriting, is done the way it should be. So what I'll show you here, we're going to be stopping and starting the video until we get it set up right. What I have here, this patient has indicated, you'll see this is your contact information, your license information, etc. There's over here that says driver ID verified by. You always leave that blank because I'm the one who fills that out. And that I fill in there whatever type of picture ID you presented with. That's what it's for. A lot of people ask me, what do I have to bring with me? Besides payment, obviously, is a picture ID. And the other things you might have to bring with you. There are only 2 other things. I will go over those with you in a second. So there's a section here on the front page that asks if you have ever had any kind of operations, and if you're on any kind of medications underneath there. So this patient indicated he had these operations and what year he had them. That's really all I need to know. And we don't really need to go all the way back if you had a tonsillectomy when you were 2 years old. That's not so critical as if you had open heart surgery. So generally the DOT says, well, we want a 20-year history on you. Yes, but if you've had something major like a heart operation or some sort of neurological condition like brain tumors or something like that, or a knee or hip or shoulder replacement, yeah, let's go back more than 20 years. Now you see this guy's on a list of medications. It says see enclosed list. I do take list from your treating doctor, if you have such a list. And if not, you can just list all your medications right here. One other thing this patient did right was on page 2, there's a page 2 that you, the driver, needs to fill out. Just go through the checklist, yes or no, or something you may not be sure of. So this guy not only put the checks in the right place, he also indicated, well, for number so-and-so where I checked yes, this is what it was. And he did that for each item. So even if you don't indicate it, I still go through that part of the history with you before I actually do the actual physical exam. So, but this guy did it right. So, what are some other things that you may need for your physical? Well, there are 2 other situations where we might need more information. First, if you take insulin to treat diabetes, there is such a thing as an insulin compliance report that you need to take to your doctor, and your doctor, the one who prescribed the insulin and is monitoring your diabetes, I need to receive that 4-page report directly from your doctor before I can do your physical. The other situation is if you use a CPAP machine for sleep apnea, then I need something called a compliance report. Now, I'm going to revisit insulin later on in the actual physical exam when I talk about some of the abnormals we're looking for in the exam. But I'm going to touch on something about the CPAP compliance report. Yes, bring this along because there's something I'm going to look at first. You see that number there? It's called, I don't know.
Yep, it shows up.
Okay, AHI. Some compliance reports just have AHI, but this one has AHI spelled out. What it means, that's the number I'm looking for. And you see here, it's 3.5. Well, guess what, folks? This guy was incorrectly diagnosed as having sleep apnea. If that number right there is less than 5, you don't have sleep apnea. And don't get suckered into buying a CPAP machine when you don't need one. So that's something I see with a lot of these clinics that I like to call them for-profit doctors out there, or clinics that have this gimmick where they'll measure a patient's neck, say, well, you're kind of big, and we're just going to send you for a sleep study. Yeah, that's BS. There are actually 4 different criteria or direct observation to say, yeah, there's a good chance you might have sleep apnea, then we're going to send you for a sleep study. And I have sent people for a sleep study, as I did with this patient right here, because some people say, well, I don't believe in sleep studies. Well, hey, I'm a respiratory therapist as well as the medical examiner. So I have a little bit more insight into sleep apnea and other respiratory diseases than most medical examiners do. Because I was a respiratory therapist long before I was doing this stuff. So yes, I did send this guy for a sleep study. But anyway, If your AHI number is less than 5, you can pretty much throw the CPAP machine away. You don't need it. Now, if this one is great, or if you have what's called a CAHI number, then I'm going to look a little bit more closely at it. So if this number is 30 or more, then yeah, you have pretty severe sleep apnea and you need that CPAP machine. Then I'm going to look at your usage. It has to be 70% or more for longer than a 4-hour period. And it even says here, days at least with 4 hours usage of your CPAP machine. That number has to be 70% or greater. Anyway, and if it's not, then yeah, you're not going to pass your physical. Okay, so I dispelled some myths about CPAP usage and sleep apnea, or OSA, obstructive sleep apnea. Central sleep apnea, that's a totally different ballgame. And if somebody's going to send you for a sleep study because of a DOT physical, they're not suspecting central sleep apnea. That's, like I said, a totally different ballgame. Anyway, okay, so, but like I said, I will, some patients, if I find stuff that is abnormal, and sometimes if I think you may not be telling the truth, that does happen. I'm going to give you one of these letters, and you might get it in the mail the next day or something, where it says, you need to get these tests done for further examination, and I will write up an order of tests you may have done for further evaluation, as I did for this patient. Sleep study is one of them, and other things. And if I don't receive them by a certain date, as you see here, I put the date I need to receive all that by, then you're not welcome back for your next physical. Not in this office. So there are a couple of things I wanted to show you at the computer to back up all this, what I just said.
Okay.
Let's move to the computer. Okay, according to this organization called sleepapnea.org, the apnea-hypopnea index, the AHI number, and an AHI score lower than 5, that's normal healthy breathing, you don't have sleep apnea. 5 to 14, it's mild. 15 to 30, moderate. 30 or higher, it's severe. In fact, they recommend through studies that if you have mild sleep apnea, 5 to 14, you don't really need treatment with CPAP. So that's another thing to consider. And some people will argue, or some doctors may argue, well, the number changes after treatment. No, according to this study, no, it doesn't. Not significantly so. So again, don't worry about it. Okay, jumping a little bit further here. At the end of the physical, when I give you your card or your medical certificate, if you pass everything, I'll give you your card right away. And this is the actual FMCSA's website that I log into, and I obtain your card right away. And then at the end of the history taking part, which is what you, the driver, fills out, you just sign it and date it, And remember to be truthful. As it says right here, if you're not truthful, you could be penalized, as what happened to this guy. Guy right here actually got arrested and sentenced for making false statements on his DOT medical form. So it can and will happen. You may lie to one medical examiner, but you can't lie to a bunch of them. And if the officer of the law who pulls you over for any reason, like you've been in an accident and they need to know your history, they're gonna call on me or your medical examiner to see what information you've been reporting. And as you see here, it can and does happen. So please be truthful. Like I said, I was a respiratory therapist before. I've been examining people in various capacities for 41 years. So you may be able to pull the wool over my eyes, but don't make a practice of it, because it will catch up to you eventually. Okay, now this is your actual physical exam, which is my part. Everything that's on here, I check. People have told me, well, you check more than most examiners, and that's why I like to be thorough. But I do go through it pretty fast. So most people are in and out of here from the time they sit down to do their paperwork to the time they're walking out the door with their card is an average of about 40 minutes. Now some people might say that's too long, but like I said, I check a lot of things. So, we already did a video where I go through and do the whole exam. So with Amanda, we're just going to demonstrate some of the abnormal things they may encounter while doing the physical. The first being with the blood pressure. Alrighty. Okay, this pillow I always use for you to rest your left arm on, like that. And the left arm is usually the one that's used, mainly because of the anatomy. Blood pressures are generally lower on the left side. Now, as I'm doing a blood pressure, okay, put your arm right in there. Now this is what you call a D-clip blood pressure cuff. So it just quickly fastens like that. And my stethoscope, some people will say, I've never seen one like that. I turn it on, pump up the volume, and now I can hear. And the reason why I got this thing is because I'm in a mobile setting. And a lot of times I'm sitting at a truck stop with all these diesel engines idling around me. So that's the main reason why I got this thing. And I take a blood pressure as normal. Now, I always use a manual one. I actually do the pumping up and reading the numbers, and I'll hear your pulse, boom, 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 through the stethoscope to tell me what the top and bottom numbers are. Why don't I use the digital ones? They are so inaccurate. They generally read a lot higher than what your blood pressure actually is. So let's say I took her blood pressure and the number is, let's say, a little bit above 140 for the top number, and the bottom number is a little bit over 90. Well, that's slightly elevated. So in that case, I'm going to double check her blood pressure throughout the course of the physical to see if it comes back down to normal. If it does, let's say at the end, her numbers end up about 136/80, something like that. That's normal. And then I'm not going to count that against her. Now, here's another thing, and some medical examiners will do this, but most cardiologists will not. They'll see a number, maybe what I just said, 186, or 136/80, and say, well, you're close to high, but we like to recommend you start taking blood pressure medication as a precaution. BS, don't do it. 140/90 is the cutoff. And if you're close to it, yeah, you want to keep an eye on it, but don't start taking medications where you don't need to. Because they have done studies on people who've done that, and they ended up with all sorts of other problems, mainly kidney issues. So, yeah, you don't want to be taking blood pressure meds when you don't need it. Now, let's say her blood pressure is 180, the top number is 180 or more. Or let's say the bottom number is, I'll say 110 or more. Yeah, you're not getting a card today. You're not going to pass your physical because obviously your blood pressure is way too high and it does need treatment from your medical provider. Now, let's say she's slightly elevated, and I'm going to just check it throughout the course of the exam. Well, here's what I'm going to do. Let's take this off, which a lot of people have never seen before. And I have a lot of people saying, what on earth are you doing? I will take just a regular old blood pressure cuff. I was using one of the larger ones there. And when I double check, turn it around like that, I'm going to use a smaller cuff on the forearm. And those of you who have worked on ambulances 30, 40 years ago, like I have, will know exactly what I'm doing. This is what you call taking a blood pressure by palpation. Now only the systolic number, the top number, can be obtained using this method. And actually taking your blood pressure, yours is 132, the top number, which is okay. So we're going to take this off now. So now based on that, I'm not going to worry about it. And that's the blood pressure that I will record if I had to double check somebody's blood pressure using what's called the palpatory method. Alrighty, so while we're on the topic of my stethoscope, I'm going to listen to the patient's heart and lungs. So I have my trusty old stethoscope here with the amplifier. So I'm going to listen in all these different positions. 1, 2, 3, 4, 5. Those are the positions where I'm listening to each of the valves in the heart. So what am I looking for? Or what am I listening for, I should say? I'm listening for any signs, mainly any signs of irregular heartbeat, any signs of leaky valves. That's the other main thing I'm listening for. And what does a leaky valve sound like? It sounds like instead of a boom boom, boom boom, I'll hear a boom shh, boom shh. And those are some of the abnormal things I'm looking for. Each position is a different valve of the heart. And now I'm going to take a listen to your lungs. I can lean forward a little bit. 1, 2, 3, 4, 5, 6. I'm going to hold in several seconds in each position so I can hear both the in-breath and the out-breath. Why all the different positions? Well, it's not just because the lungs are so big vertically, but because they are divided into sections. So she may have some wheezing or abnormal sounds here, but the rest of the lungs be perfectly clear. And I actually had a patient like that about 2 years ago, where just in one spot, it was one of the upper sides here, I heard some wheezing, and not in the rest of his lungs. The rest of his lungs were perfectly clear. And I made mention of it. Now that's not something that's going to limit his certification in any way, but it is something that he needs to get investigated by his doctor. And he did. And guess what? The guy ended up having a tumor growing in his lung. So, and that was surgically removed, and then he was fine. Okay, while we have Amanda sitting here, we're just going to go ahead and demonstrate all the stuff I'm going to be checked while she's sitting, because I do go in a different order in the actual exam. Next, I'm going to check your hearing. So what I'm going to do is I'm going to stand at least 5 feet away, and we know from measuring before, and you actually see me measuring in the other video, this is 5 feet. And I'm going to whisper a couple words, and you're going to repeat what you heard. Okay, so first cover your left ear.
I know I heard something, but I don't know what you said.
Let's try a different word. Baseball.
Facebook?
Well, you got the sounds right, and that's what I'm looking for. So the word wasn't right, but the pitch and the sounds were okay. So I'm going to pass the person on that. Now, if you can't hear anything, so I'm here whispering away several different words, you can't hear a thing. Then it's time for the beeping test. Yes, I do the beeping test with you wearing these headphones, where I do have a program on the laptop that sends beeps through the headphones, and then you just raise your hand whenever you hear them. And if you're having trouble with that, then I'm going to send you out to an actual audiologist to check your hearing. And now with some of the relaxing of the rules nowadays, using this is a rarity anymore. But I used to commonly use these. Now, in general, the only thing I have people actually take off is their shoes and socks. And of course, both feet. But I'm just demonstrating on the one foot. So what I'm checking for, and I showed all that in the other video, but what do some of the abnormal things look like? Well, if she's somebody with diabetes, who doesn't take care of herself, or the diabetes has gotten out of control, I'm going to see a discoloration of the toes, especially like a bluish or blackish color if it's been going on for a long time. But normally I'm going to check circulation like this and see how her toes pink right up again. That's normal. However, if you can see how if I push, the toe pinks back up again. But if it remains white, like see how it's white when I take my finger away? If it stays white like that for a prolonged period of time, that tells me you have some sort of circulation problem going to that foot or that toe or on that side of the foot. Either some sort of atherosclerosis or arterial disease or a blood clot even. For somebody who does long haul driving across country, that's usually caused by maybe some sort of blood clottage or something. But I'm also checking the pulses with the one on top of the foot, the one behind the ankle on the inside of the ankle. So another thing that I'm checking for is these feet may get puffy and big and enlarged in somebody with heart disease or blood pressure that is not well controlled. So if I see that, as well as other signs of some sort of heart problem, like the heart, the valve leaking, like what I listened to, then I'm going to say, look, I'm going to refer you to a cardiologist so you can get that stuff checked out. Because last thing I'd want to do is certify somebody who's going to go out and have a heart attack because they didn't take care of this. Okay, so we're going to check some ranges of motion to see how everything is working as far as movement goes. Are you able to move around? Okay, first off, you reach down and touch your toes. Come back up. Okay, twist to the left. Yep, to the right. Now your other left. There you go. Okay. Now turn your head to the left. Got some issues there? Mm-hmm. Okay. I'm going to look at that a little further. Now, of course, that's most likely a case for a chiropractor, but that's something I'm going to note, that she has trouble turning her head to the left, which could interfere with how well can you see off to the side. So that can affect somebody's ability to drive safely. Okay, turn your head to the right. Okay, look up. Keep looking up and close your eyes. Oh, see, she fell over. She almost fell over. That's what I'm looking for. People, and I have had one person who did this. He was intoxicated and in my office.
Oh my God.
Because that, looking up and closing your eyes, tests your cerebellar reflexes. The cerebellum is the part of the brain in the back which controls your motor movement and your balance. So you saw there when she looked up and almost closed her eyes and fell over, there's something wrong with that cerebellum. And that needs to be investigated by a neurologist. So that's something we're going to take a closer look at. What we're going to look at next are reflexes. Most doctors, they just bang on the knee a couple times and that's what they check. I check a lot more than that, because you have a lot more than that, especially those that are going to affect your feet, your leg movement, and your arm movement. So I check. Now usually I do this when I'm doing the feet, the shoes are off. So I'm going to be looking at, okay, L5, L4, here below here, waiting here. Alrighty. Now, you're not always going to get a good kick like you see in the movies where you're about to get kicked across the room for doing that. It doesn't always work that way. Just that little bit of a flick, that's a positive reflex. Okay, and of course I'm going to check left and right, arms and legs. Okay, now let's do the left side first. I'm gonna check C6 and C7. That is where you have reflexes. Okay, and on this side, see, now. Okay, that, you're going into a spasm. So that's an abnormal response to what should be a normal reflex. So what you should do is when I hit that elbow, a little bit of a nice flick of maybe the fingers or the wrist. That's good. But what she did was she developed a spasm. That's abnormal. That's an abnormal reflex. And that's just one example of an abnormal reflex. So I'm checking for that. That means that there's some sort of nerve damage that needs further investigation from a neurologist. Let's go ahead and do the eye test. I'm going to check your vision.
Okay.
And are you wearing any kind of corrective lenses? Like
Yeah, contacts.
Okay, you do have contact. Okay, I'm going to have you step in the hallway here. Oops. And put your toes right on that black line. And I'm going to be standing 10 feet away, which is right about where the camera is. So we'll have our, okay, now cover your left eye. We test one eye at a time and then both eyes together. Okay, what is the lowest line you can read?
EDFCZP.
Okay, so in her right eye she's 20/30, which is passable. Okay, cover the other eye now.
EP.
That's it?
Yep.
Okay, that's not passing. She has to see at least 20/40 in both eyes, one at a time, and both eyes together. She has to see at least 20/40. Now, you're already wearing corrective lenses, so that does not pass the vision test. So I'm going to have to refer her back to her ophthalmologist or optician to get those lenses checked, see if there may be something else going on with the eye. Say if she was normal, say 6 months ago, and all of a sudden not, one of the biggest things that does that is cataracts. You can go from seeing perfectly fine to nothing, just like that. So I'm going to have her come back then and we'll repeat the exam when she has that problem fixed. Peripheral vision. I always use a colored pen so you can actually see the green. I used to have a hot pink pen, but I don't know where that went. So I'm going to test your peripheral vision. I want you to put your hand right here at your nose, okay? And we're going to test one side at a time. I want you to look right at my nose and tell me when you see the pen.
No.
Okay?
No.
No? Okay. She's all the way out here before she can see it. Normal is 70 degrees or less. So if she's all the way out here, there's a problem with her peripheral vision. And for somebody that has diabetes, maybe it could be some sort of retinal or retinopathy, they call it, problem, or some other visual defect she may be having. So there's a reason why you won't pass the vision part of the exam, and I'll refer her back to her eye doctor for more testing. Okay, so those are pretty much all the abnormals, except for one more we want to do, and that's the urine test. Now, for those of you who don't have CDLs, because there are some people who have regular Class C non-commercial licenses that do need these physicals, as long as the vehicle you're driving for your work has a gross vehicle weight of 10,001 pounds or more, or if you're carrying that much weight in combination, like you're towing equipment, and you go over that poundage, you still need this physical. So this is particularly for you guys and girls. This urine test is not a drug test. If you need a drug test, that's up to the Department of Transportation and your employer themselves. They do that. And they'll tell you where you have to go, to what lab, or the lab may come to your workplace, whatever arrangement they have. The drug testing is not part of the routine DOT physical. So what we are testing for is how concentrated your urine is, otherwise known as the specific gravity. Is there any protein, blood, or sugar in your urine? Because all of those could indicate a problem. Now, for you medical examiners out there, not a lot of you know this, and I know a lot of the training courses don't even talk about this. In order to legally do one of these urinalysis, you need, I had this just sitting there, got stuck to the wall. You need one of these, an actual lab certificate from, well, each state is different, but at the Department of Health, the U.S., you have to be registered as a lab with the U.S. Department of Health first, and then you get a state lab certificate. And urinalysis is a waived, so you need one of these permits to do this. So let's look at how you do it. What we're looking for, and most places will use just these urine dipsticks. This is what I do. These dipsticks obviously have more things on them, but we're just looking at these 4 things. Like I had said, the specific gravity, protein, blood, or sugar. If any of those things are abnormal, you're not necessarily going to fail the test, but there will be need for more investigation. Now, sometimes having blood in the urine is normal. If it is, people will say, hey, I normally have hematuria, or blood in the urine, and I've been tested for it, yada yada, so my doctor knows it's there. Or women who are menstruating, they will normally have blood in their urine. So I'm not too worried about that. Or somebody who has kidney stones. I actually had a patient who had a kidney stone, didn't know it, and I saw blood in his urine. He said, oh, that's unusual. Well, the next day his kidney stone passed, because he developed all the pain associated with it. So it's kind of neat how that works. But protein in the urine, now remember back in the history where we say lists not only the medications you're on, but also if you're taking any kind of supplements. Because there are certain supplements, most notably B vitamins and protein supplements, that will put protein in your urine and make it look abnormal. Or if you're on a paleo diet, um, you'll see protein in the urine. Uh, so for that reason, it's not necessarily going to it's not necessarily going to disqualify you, or you won't be penalized for it. And then the big issue with sugar in the urine. Now that's going to take some extra testing, which let's assume that you had sugar in your urine, and we can tell because these colors will change on these strips that we have. And usually the one on the very end over here will indicate if you have any sugar in your urine. Sugar, if you're not already diagnosed with diabetes, having sugar in your urine doesn't mean that you do have diabetes. It does mean that you should have further checking to see if you do. So how do I handle it here? And how do most medical examiners handle it if they see sugar in the urine? Well, whether you do or do not have diabetes, we're going to go ahead and check your blood glucose, how much sugar is actually in your blood. And for that, here in the mobile office, I'm going to use a simple old, it's called a glucometer. This I just bought at Walmart. So it has strips. I'm going to set it up just so people see what it looks like.
Remove this, thank you.
And we know Amanda has diabetes, so I'm not going to go ahead and do this. I'm just going to set it up. And yes, to do this, it also has to show on your lab certificate as well as the urinalysis. That I can do both, the urinalysis and it shows up as whole blood glucose, CLIA waiver. That's the word I'm trying to think of earlier. Okay. So basically how you set one up, and everyone's going to be a little bit different, but this is just showing you basically the components. Of course you need your alcohol slip to wipe off a finger of hers. That's whichever finger you're going to poke. And that's all set up and ready to go. And over here we have strips that go into our monitor. And the monitor automatically turns on and waits for that drop of blood. This one's been giving me problems. There we go. And now I'm just demonstrating. I'm going to, after I wiped off her finger, let it dry a little bit, poke it by pushing that button, and you can, if you can look real closely, you can see the needle came out. It's going to produce just a drop of blood, because that's all you need, and you get that drop of blood on there, and it's going to read out a number here. If that number is 160, or between 95 and 160, it's perfectly normal. If it's higher and she doesn't have a diagnosis of diabetes already, you can tell her, well, there's a a good reason why you should go get checked by your family doctor. Because there are specific lab tests that do diagnose diabetes. Now, if that number on this is 400 or more, you're not getting a card today. You gotta go to your doctor who treats you, figure out what's going on, get your number back down to normal, and then we can redo your DOT physical. And that's about it. I don't think there's anything else I really needed to go over. Oh, one more thing I wanted to mention about diabetes. So we talked about blood sugar. I didn't say anything about A1C. Well, believe it or not, it has nothing to do with the DOT physical. I know there are medical examiners out there who say, in order for me to do your exam or for me to pass you, I need to look at your A1C. No, you don't. The FMCSA, the USDOT, nobody said you have to. There's no rule. It's nice to look at to see, okay, is the person really taking good care of their diabetes? But it doesn't factor into whether or not you're going to be certified or not. So that's about all I really have to go over. Those are all the abnormals that we've demonstrated, but certainly not all of them. But just to show you some of the things that I may encounter and have encountered over the years I've been doing this, not only here in the DOT physical setting, but in other settings, because like I said, I've been doing this 41 years. The DOT physicals I've been doing for the past 8 years. I've been a chiropractor for 23 years now. I was a respiratory therapist before that, and before that I was an EMT on an ambulance squad. So yes, I've been doing this a long time, and when people come in and think, well, he's a chiropractor, what's he going to know? Yeah, I've been doing a lot more than just being a chiropractor, and chiropractors do know this stuff, whether they're doing the DOT physicals or not. So, I'd like to thank Amanda for being a really brave soul to put up with me talking for all this time. So if anybody has any questions, you can always shoot me an email, pick up the phone and call if you want to schedule an appointment. With the mobile office, of course, we talked already about my coverage area, about me going out throughout my 22-mile radius from my Shoemakersville location to take care of individual drivers and the companies that they work for. So until next time, that's it. And in the near future, I'll be doing some videos on the actual chiropractic work that I do, demonstrating some of the techniques, and I'll be focusing more on family wellness care that I do, because I do take care of people of all ages. The youngest person I've ever taken care of was a 3-month-old baby, and yes, children do need chiropractic care, and that's the topic for next time. So until then, be safe and be healthy.